Very good morning, everyone. It's such a pleasure to be here every year to present something. And I thank the organizers for giving me this opportunity time and again. I'll be discussing about neoadjuvant immune checkpoint inhibitors in locally advanced non-small cell lung cancer. In stage 2 and stage 3 lung cancers, there is still an unmet need despite following the current standard of care using various permutations and combinations of chemotherapy, surgery, and radiation, with the 5-year survivals being grim for both stage 2 and stage 3 disease. So the immune checkpoint inhibitors, which were used mainly in the metastatic setting, trials started exploring them in the neoadjuvant and the adjuvant setting. When they're used in neoadjuvant and adjuvant, then it's called as perioperative usage of immune checkpoint inhibitors. So I'll be discussing these. The biologic rationale of giving immune checkpoint inhibitors in the neoadjuvant setting is to optimize the immune system activation. When the tumor bulk is still present in the body, the T cell activation may be more robust. And it also helps us in planning escalation, de-escalation strategies, although we don't have much data regarding this. The problem with neoadjuvant IO is there may be a potential delay in surgical resection with the small risk of progression during therapy, and there can be some immune-related adverse events which might prevent resection also. When used in the adjuvant setting, when there is an upfront surgery done, then they lower the burden of disease and they improve the patient outcomes immediately. So there's no risk of progression, but the immune environment gets disrupted, and probably the activation of T cells is not as robust. The perioperative approach is where we start in the neoadjuvant IO, we use it in the neoadjuvant setting and continue as maintenance. Pembrolizumab is approved for that so far. Nivolumab is not yet approved, and durvalumab is approved by the EMA but still not approved by the FDA. That's pending. So these are the various phase 3 trials that used IO in resectable NSCLC. Pure neoadjuvant setting, we only have Checkmate 816, and the remaining are all mostly perioperative, and these are the adjuvant trials. So these are the 4 important trials with the drugs which are commonly available for us now. And if you look at these, all the trials took mainly stage 2, stage 3 patients in whom neoadjuvant chemo was warranted in general, except Checkmate 816 that had stage 1B patients as well, that were more than 4 centimeters. All of them used platinum-based doublets as their neoadjuvant regimen along with IO. All of them except Checkmate 816 had a maintenance phase with the IO drug. Checkmate 816 just had 3 cycles of nivolumab along with chemo at 360 milligrams dose. And all the endpoints were more in favor of neoadjuvant chemoimmunotherapy rather than neoadjuvant therapy. If you look at the surgical outcomes in Checkmate 816, the R0 resections were superior. The cancellation of surgery was also numerically lesser in the neoadjuvant chemoimmunotherapy arm, and surgery being cancelled due to progression, which is our worst fear, was seen in just 6.7% of the patients as against 9.5% with chemotherapy only. The median duration of surgery was also shorter. More patients could undergo minimally invasive surgeries that led to better and faster postoperative recovery. Pneumonectomies were less common. Patients could get away with lobectomies. And these differences were much more pronounced in stage 3A disease. If you look at the 4-year EFS update, it is 49% versus 38%, and statistically significant hazard ratio of 0.66. The overall survival, although numerically was superior, the hazard ratio did not reach their level of the preset level of statistical significance. The lung cancer specific survival was also numerically superior. But in patients who achieved a pathological complete response, they continue to have a statistically significant better overall survival than the chemotherapy arm. And the EFS benefit was seen despite the fact that a certain proportion of patients in both the arms received some chemotherapy in the adjuvant setting as well. Despite that, there was a statistically significant EFS benefit that was seen. And if you go for the subgroup analysis, the groups which benefited the most with respect to EFS by the addition of nivolumab in the neoadjuvant chemotherapy is Asian population. Stage 3A patients benefited the most. non-squamous histology benefited the most, and PD-L1 expression being 1% or more. The other subgroups also benefited, but the magnitude was much, much higher in these 4 subgroups. Pathological complete response was better with Nivo chemo across all the subgroups. So with this trial, a trial level association between pathological complete response and survival in NSCLC, which could not be shown prospectively till date because of the rarity of PAT-CR, as Dr. Swaratika had highlighted that it's just around 4-5% the PAT-CR with neoadjuvant chemotherapy. Now that got pushed to a much higher number so that a trial level association between survival outcomes and PAT-CR could be very robustly established with CheckMate 816. And if you look at the adverse events, they were not significantly higher in the neoadjuvant chemoimmunotherapy arm, and most of the immune-related adverse events were also of a lower grade, grade 1, grade 2. It did not increase the surgery-related adverse events or impede the feasibility of a surgery. So 3 cycles of neoadjuvant Nivo plus chemo improved long-term clinical outcomes in patients with resectable stage 1B to 3A non-small cell lung cancer without impeding the feasibility of surgery or increasing the incidence of adverse events as compared to chemotherapy alone. Almost 2/3 of the patients were stage 3A patients here. Now, if you look at Keynote 671, it tried to explore the effect of the addition of IO in the perioperative setting, and it looked at EFS and OS rates. This was the trial design. I will not go into the detail. It had a maintenance phase of pembrolizumab for up to 1 year. If you look at the R0 resection, the pembro arm had a 92% R0 resection as against 84% in the placebo arm. And if you see the reasons for cancellation of surgery, because of progressive disease, it's just 3.8% as against 6.5% in the placebo arm, and clinical progression was seen in less than 1% of the patients. The EFS was superior, and it had a statistically significant hazard ratio of 0.58. And across the key subgroups, irrespective of the nodal status, histology, PD-L1 expression, there was EFS benefit across all the subgroups. The overall survival hazard ratio was 0.73. Again, this did not reach their preset limit of statistical significance, so probably more data maturity is required. The pathological complete response was also 18% versus 4%, and major pathological response was 30% versus 11%. If you look at the EFS by pathological response, major MPR and PAT-CR, the patients even on the placebo arm who achieved a MPR or a PAT-CR, they did much better than the pembro arm who did not achieve the same. So that again points out that MPR and PAT-CR are very robust clinical endpoints because they are directly correlated with the survival endpoints. This is the AGN trial, which is a phase 3 trial of durvalumab, similarly in the perioperative setting, started in the neoadjuvant setting with a platinum doublet followed by continuation. And here again the endpoint was EFS, one of the primary endpoints, which showed to be statistically significantly superior with durvalumab as compared to chemotherapy alone. Again, the PAT-CR and MPR rates were significantly higher in the IO arm. So this is a side-by-side comparison of all the 3 major trials which are currently driving our practice, CheckMate 816. And an important point is that in CheckMate 816, EGFR and ALK alteration patients were excluded. That is very important because we know that this is a subset which probably doesn't respond that well to IO. And so all of them showed better pathological complete responses and major pathological responses. So as clinicians, what are the reservations that we have to incorporate IO into the neoadjuvant setting along with chemotherapy? One is fear of progressive disease that precludes surgery, fear of immune-related adverse events like higher grade pneumonitis, which can again make surgery very difficult, other reasons which may lead to cancellation of surgery, and financial toxicity. But if you look at the financial toxicity, the CheckMate 816 regimen, which is 3 doses of nivolumab only in the neoadjuvant setting, without having to use it in the maintenance phase, still it could demonstrate a superior EFS and pathological complete responses. So which may be feasible for many patients. The maintenance may not be feasible, but with good patient assistance programs from the companies and hopefully a further price reduction in the future, we'll be able to pass on the benefit for more number of patients. Now, the cancellation of surgery due to progressive disease, is it a point of concern? As I said earlier, the reason for surgery cancellation due to progressive diseases, the percentages are very small and they're numerically lesser than on the chemotherapy arm. And reason for cancellation being due to an immune-related adverse event was not reported separately in most of these trials, but the immune-related adverse events also, most of them were grade 1, grade 2 and did not cause much of a progression. So overall, up to 7.4% of the patients only had progression on neoadjuvant chemoimmunotherapy. These patients could have benefited from an upfront surgery, but they're also likely to develop an early metastasis. So there is a clear gap in our understanding of the best strategy for these patients, and there are challenges in the feasibility of conducting such trials as well. Downstaging of disease also is possible with this, so that leads to less morbid resections. So I'll just take another half a minute. Neoadjuvant chemoimmunotherapy, this was a latest systematic review and meta-analysis that included a lot of trials. 8 were randomized control trials. These were the drugs that were tested, and these drugs are the ones which are available for us, and most of the patients were contributed by these drugs. And if you see, especially, there was an overall survival benefit in patients who had a PD-L1 of 1% or more, as well as in stage 3 disease. The EFS estimates also favored neoadjuvant chemoimmunotherapy, and this was seen across all the subgroups, irrespective of the histology, the stage of the disease, and the PD-L1 expression. Pathological outcomes favored neoadjuvant chemoimmunotherapy. The patients were more likely to undergo surgery in the neoadjuvant chemoimmunotherapy arm, more likely to have R0 resections, more lobectomies as compared to pneumonectomies. So the final conclusions of the meta-analysis were that addition of immune checkpoint inhibitors to chemotherapy leads to a better OS, especially in patients with a higher PD-L1, 1% or more, better EFS, better pathological responses, reduced risk of not undergoing surgery, reduced risk of progression precluding surgery, improved resectability with similar adverse events. But there are some persistent questions. We don't know what the appropriate adjuvant treatment strategy is in these patients who have received IO in the neoadjuvant setting. Currently, there is limited evidence to suggest superiority of perioperative approach over a purely neoadjuvant approach. We don't have such a trial. And progressors or neoadjuvant therapy, overall a poor risk population who are likely to not do well with upfront surgery. So for any patient who deserves neoadjuvant chemotherapy, who mandates neoadjuvant chemotherapy, addition of immunotherapy definitely has a benefit irrespective of the PD-L1 expression, because EFS benefit is seen across all levels of PD-L1 expression. Thank you very much. I'm happy to take any questions.
So thank you so much. Very well presented. So you have shown very clearly the benefit of addition of IO to chemotherapy irrespective of EFS or MPR or progression-free survival, but overall survival we still need to wait for the data to mature.
Yes.
So like a previous speaker said, that perhaps performance status was one of the criteria where we inhibited using chemotherapy. So if a patient has not a good performance status and not a candidate for chemotherapy, can IO only suffice as a neoadjuvant treatment, and with what data?
Probably IO, we have in Checkmate 816, there was an arm with ipilimumab and nivolumab, although the number was small in that, but definitely the results are promising. So we can, in patients who have a poor performance status, using purely IO without any chemotherapy is also a reasonable approach, especially if PD-L1 is more than 1%, but Nivo-IP combination, irrespective of that, we can still use.
So can this be a message to the house, to the students sitting here, that for patients who do not have a good performance status with a high PD-L1 at least more than 1%,
yes,
that can
at least we can consider. Yes, yes,
right.
Absolutely.
Okay, then any question from the house? Yes, there is some. Yes, please. You want a mic?
Good morning. Last 2 or 3 slides you mentioned that with adding neoadjuvant immunotherapy, it is reducing the risk of progression during that period. But I contradict that with the Checkmate nivolumab trial, that I don't think there is much difference in the risk of reducing the surgery. It is in nivolumab it is around 17% and the chemotherapy around 25%. So in the patients who are let's say 1B to stage 2, why would I still be too optimistic, by giving neoadjuvant immunotherapy and chemotherapy? Patient might can progress during the immunotherapy, and I can miss the benefit of surgery upfront.
Right. See, across all the trials, it was numerically lesser. The trials were not powered to detect whether that difference was statistically significant, but at least it was shown that it's definitely not more than the neoadjuvant chemo. Now, we don't have like upfront surgery versus neoadjuvant and what is the comparison between them, because when trials were evaluated for adjuvant or neoadjuvant, it was not those kind of trials where we upfront operate and then we give neoadjuvant and then operate and see how many. The comparison here was between neoadjuvant chemo and neoadjuvant chemo immuno. So if we go for upfront surgery, what is the risk? How many? Upfront surgery, obviously the risk of progression will not be there. They'll immediately, the tumor is removed completely. But what we are trying to show is, compared to chemotherapy, the progression on systemic therapy was numerically lesser in immuno. And immuno has its own advantages of long-term. The long-term outcomes like EFS, definitely it showed a benefit. So if you decide to give neoadjuvant chemo, then adding immuno to that will have added benefit for the patient. That is what is the message. Now, whether to give neoadjuvant or not in the resectable, that is something which was already discussed by my previous speaker, Dr. Swaratika. So that again, like on a case-to-case basis, we obviously have to take a decision. Predominant drivers would be if there are any comorbidities we are trying to optimize, or borderline resectable or heavy nodal burden, we would like to introduce systemic therapy first with very close monitoring for progression. I think that should be the way forward, but not like a blanket in every patient.
So if there is a surgeon in the house who contradict that, is said that even if you are debarring a patient from neoadjuvant chemotherapy or chemo, whatever, and you have resected and the disease has come back very soon, it's as if it's a bad disease. The disease, if you had you operated upfront also, would not waited for a neoadjuvant, and within a couple of time you found that the disease has come back, some having a, and we thought that we missed the train, we should have operated upfront. That's a bad disease. Even if it had operated, the disease would have a metastatic potential. So with this, thank you so much.
Thank you.
And I'd like to invite.
Thank you.